Bismillah ar-Rahman ar-Rahim. Today I want to talk to you about the subject of hyperhidrosis. The reason is because this subject is not an easy one, and there is a lot of neurology in this subject, and this happens to be my favorite subject. Now, to start with, let's have an idea about sweating. Of course, as you know, sweating has an important thermoregulatory function. It helps in the control of the body temperature. And the way the body cools itself is by two methods. The first one is the vasodilatation of the skin that increases the radiant heat from the body. And the second one is the evaporation of the sweating. Now, as you know, the sweat is primarily produced by the eccrine sweat glands, and this can lead to dissipation of heat and evaporation and cooling of the body. There are about 2 to 5 million eccrine glands in the body. They are unevenly distributed over the skin surface. How much we sweat? It was studied and found that the average healthy adult can produce over a half a liter of sweat per hour. That means around 12 liters per day. And of course, 99% of this is water. Athletes and other people acclimatized to hot weather can produce more than this amount. They can produce 3 to 4 liters per hour. As you know, sweating is controlled by the nervous system. And the best way to understand the sweating and then hyperhidrosis is to understand the sweating reflex, or what we call pseudomotor reflex. Pseudomotor means sweating. There are pseudomotor impulses imported from various parts to the body. They are integrated in the anterior hypothalamus, where the sweat centers are present. From the hypothalamus, there are tracts called reticulospinal tracts descend into the spinal cord and pass to different levels of the spinal cords. From there, they pass through the rami communicantes into the autonomic ganglia. So the sweating is controlled by the autonomic nervous system, and specifically the sympathetic nervous system. Usually, the sympathetic nervous system is adrenergic, but the sympathetic neurons to the sweat glands are cholinergic. This means that they produce acetylcholine and they induce sweating this way. Now we come to the main subject, which is the hyperhidrosis. Hyperhidrosis means excessive sweating. And we will discuss later how can we measure the sweating, but in general, when the sweating becomes bothersome, then we can call it hyperhidrosis. There are two main types of hyperhidrosis: primary, in which there is no underlying pathological condition, and the secondary. The primary hyperhidrosis is more common, and typically it affects the palms and soles and sometimes the axilla, but it can also affect the face. While the secondary hyperhidrosis, there is an underlying condition. It could be genetic, could be infection, a tumor, or a drug. And the secondary can be localized or generalized. And it is estimated that the hyperhidrosis, and mainly the primary, affects around 33% of the general population. Let's start discussing the primary hyperhidrosis, and as I said, the main sites are the palms, the soles, the axilla, and sometimes the face. This primary hyperhidrosis is also called cortical, referring to the cerebral cortex. It means that the cerebral cortex has a control on this type of sweating. Stress and emotion generated in the cerebral cortex will work on the nervous pathway, which we have just discussed, and will increase the sweating. One of the fundamental features is that the primary hyperhidrosis or the cortical hyperhidrosis only takes place during waking hours. That's why it's called diurnal. Patients, of course, are otherwise healthy, and up to 80% of these individuals have one of their family members also affected. There are set criteria for the diagnosis of the primary hyperhidrosis. First of all, it's not generalized, it's focal, and there must be visible sweating. It must be present at least for 6 months, not 1 or 2 months. And there are, of course, no apparent secondary causes. In addition, you have to find 2 of the following to consider them as a primary hyperhidrosis. They are bilateral and symmetrical. They, of course, interfere with the activities of daily life. They are not simple. And there must be at least 1 episode per week. Usually the age of onset is less than 25 years. I mean, it's very difficult to diagnose them in old people. And there is usually a family history. And as I said before, they stop during sleep. Now we come to the other subject, and we are going to discuss the secondary hyperhidrosis, in which there is an underlying pathology. This subject can be divided into the sites, the neurological sites in which the hyperhidrosis is generated. So we'll start with the disorders associated with cerebral cortex hyperhidrosis. These can be stimulated by emotional and stress, like the primary hyperhidrosis. But here there is another pathology that enhances the process of hyperhidrosis. What are these pathologies? For example, pathologies that are limited to the hands and soles. For example, disorders of cornifications. Palmoplantar keratodermas are usually associated with hyperhidrosis. Pachyonychia congenita and other disorders of cornification. There are certain genodermatoses that are associated with hyperhidrosis. For example, epidermolysis bullosa, especially of the simplex type. Dermopathia pigmentosa, also. Dyskeratosis congenita and other genodermatoses that usually affects the palms and soles and lead to hyperhidrosis. In addition to these abnormalities, there are abnormalities in the sensory and autonomic nervous system that controls the sweating. Of course, this has a direct effect on the sweaty glands, and it can cause cortical hyperhidrosis. For example, familial dysautonomia, Riley-Day syndrome. Other autonomic dysfunction syndromes like congenital autonomic dysfunction with universal pain loss and congenital sensory neuropathy. In these syndromes, hyperhidrosis is a well-recognized feature. Now we leave the cerebral cortex and we descend to the hypothalamus, in which we said the sweating centers are situated. The hypothalamic, of course, has a thermoregulatory function. So sweating here, hyperhidrosis, is called hypothalamic or thermoregulatory hyperhidrosis. Here, elevated body temperature, elevated blood temperature will induce stimulation of these centers in the hypothalamus, leading to hyperhidrosis. For example, any acute febrile illness, certain tumors that raise the body temperature like lymphoma, chronic infection like TB, and there are stimuli that act directly on the hypothalamus, like pheochromocytoma, toxins, medications. Here, as you all know, the hyperhidrosis may be nocturnal, characterized by night sweats, or sometimes diurnal, same like the cortical one. Here I list some of the causes of the hypothalamic hyperhidrosis. Of course, acute febrile illness during the defervescence, not the rising temperature, tuberculosis, night sweat, brucellosis, malaria, subacute bacterial endocarditis, tumors like lymphoma, carcinoid, pheochromocytoma. There are certain endocrinological and metabolic diseases that cause hypothalamic hyperhidrosis. For example, hyperthyroidism, acromegaly, hypoglycemia by reflex can cause hyperhidrosis, and you are well acquainted with the menopause sweating. Vasomotor lesions can induce, vasomotor disease can induce hypothalamic hyperhidrosis. How? For example, congestive heart failure. You know, people who have congestive heart failure, they have more and more sweating. Why? In congestive heart failure, there is sympathetic stimulation, but at the same time, the vasodilatory response is impaired, while the sweating response is well preserved. So these people sweat more than usual. Myocardial ischemia is associated with hypothalamic hyperhidrosis, Raynaud's phenomena, and other diseases as well. There are certain neurological diseases and CNS diseases and tumors that act directly on the hypothalamus, inducing hyperhidrosis. For example, CVA. Parkinson's disease is well known, and you have noticed that before. It can induce hyperhidrosis. People who had encephalitis, post-encephalitic, sometimes they have generalized and stationary hyperhidrosis. Now we go to another level, to a lower level, and that the medulla oblongata. Here we have the gustatory hyperhidrosis, gustatory related to taste. You know that the taste receptors in the mouth are the source of afferent impulses that reflexly will stimulate sweating. All of us sometimes experience what we call physiological medullary hyperhidrosis, wherein we ingest spicy foods, citrus fruits. Sometimes we have a reflex sweating and erythema on the forehead and the face. This is physiological. But there are also pathological medullary hyperhidrosis. Here there is a certain mechanism. A disrupted nerve for the sweaty glands, instead of connecting the right way, they are connected to the nerves of salivation. Why? Local injury or disease in the parotid glands, where the autonomic nerves to the sweaty glands of the face and the salivary gland, the motor nerves to the salivary glands are lying near each other. There will be interconnection, and instead of a stimulus that induces salivation, this stimulus will induce sweating instead or together with the salivation. Causes of medullary or gustatory hyperhidrosis. As we said before, physiologic, but there is a Fry syndrome, which is associated with, is related to the diseases in the parotid glands. The chorda tympani syndrome, disease in the same area. Cluster headaches and sympathectomy are sometimes associated with medullary or gustatory hyperhidrosis. Now we descend down to the spinal cord. Again, spinal cord lesions and the transection can induce hyperhidrosis. Here there will be a lack of thermal sweating below the level of the injury, but with an unusual pattern of the hyperhidrosis at the level of the injury. There will be mass reflex sweating, usually at the level of the injury, as I said before. Causes of this could be spinal cord injury, syringomyelia, or tabes dorsalis. Again, we go lower down to the autonomic ganglia. Autonomic dysreflexia can cause hyperhidrosis. How are they stimulated, these autonomic ganglia? Direct stimulation, electrical, physical, drug-induced, of the ganglia or the sympathetic axon nerve can cause sweating. Here, some of the inflammatory skin diseases, they can act on the sympathetic axon nearby and induce hyperhidrosis. Autonomic dysreflexia is a syndrome that may occur with spinal injuries at or above the level of T6. Massive episodic sympathetic discharge. This is the explanation of and the description of the syndrome in which there is a spinal cord injury. Sympathetic massive discharge with the sweating, headache, and hypertension with the facial flushing. Now we go to our subject, in which some of the inflammatory diseases like psoriasis and dermatitis. Here the mediators of inflammation can act locally on the axon and induce hyperhidrosis. Here it is said that substance P plays a role in this subject. Now we have finished so far the neurological event. We go to another subject, compensatory hyperhidrosis. This means loss of sweating in one part of the body will induce sweating in another part. But the sweat glands that are not functioning must be of magnitude. There is a threshold for the number of sweat glands that must be non-functional. You all familiar with that patients with miliaria, especially if extensive, they can have compensatory sweating of the face. Diabetic neuropathy, involving usually the legs, these people have compensatory hyperhidrosis of the back. And post-sympathectomy hyperhidrosis also may be accompanied by compensatory hyperhidrosis. Another non-neural hyperhidrosis, in which we can call local hyperhidrosis. Direct stimulation of the eccrine glands can cause sweating, even when these sweat glands are denervated. How are they stimulated? Triggers can include local heat, drugs, and vascular tumors. Heat or pseudomimetic drugs can lead to localized sweating, even in denervated glands. Causes of abnormal. Why there is an abnormal blood flow and heat of this area? For example, eccrine angiomatous hamartoma. If there is a lot of blood vessels, they raise the temperature of the sweat glands and they induce sweating. Maffucci syndrome, blue rubber bleb syndrome, and other lesions that will lead to increased vascularity and increased blood flow and increased heat of the area, thus stimulating the sweat glands. Another important subject, which is always present and can produce anything, is that there are drugs. Drugs can stimulate the eccrine glands, of course. Some of these drugs are direct-acting cholinomimetic agents. They have the same function as acetylcholine. Anti-xerostomia drugs. There are drugs that inhibit the cholinesterase enzyme that degrades acetylcholine and increases the level of this substance. For example, anti-Alzheimer drugs, anti-cholinergic antidote, and anti-myasthenia gravis. There are other drugs that induce sweating, adrenomimetic drugs like dopamine, epinephrine, norepinephrine, and others. Anti-diabetic drugs, by inducing hypoglycemia, can induce hyperhidrosis. There are certain CNS stimulants that can also cause hyperhidrosis, amphetamines, caffeine, and theophylline. A very important group of drugs that induce hyperhidrosis is the antidepressants of the three classes. MAO inhibitors, SSRIs, and the tricyclic antidepressants all can cause hyperhidrosis. Antipsychotics also can cause hyperhidrosis. Antipyretics, opioids, as well as other drugs, for example, ACE inhibitors, in addition to other drugs that can cause hyperhidrosis. Now we have so far discussed the etiology of the primary and the secondary hyperhidrosis. Now how can we diagnose this subject, hyperhidrosis? First, we have to differentiate between primary and the secondary hyperhidrosis. Are there ways to measure sweat and sweating? Yes. There are crude measures and there are accurate measures. Of the crude measures, there is a grading scale for the volar hyperhidrosis. A low hyperhidrosis when you have moist palms or soles without visible sweating droplets. The moderates when the droplets reach the fingertips, and the severe when there is dripping of sweat. Usually on papers that these students or pupils have difficulty in performing exam. They have great sweating so that the paper gets wet. Axillary also can be measured roughly. If there is less than 5 centimeter staining of cloth, it's considered to be normal. 5 to 10 centimeter mild, 10 to 20 moderate, and more than 20 severe. Of course, this depends on the ambient temperature. There are more accurate tests for the colorimetric techniques such as starch iodine. You're all familiar with it. But here this demonstrates the pattern of sweating and the location of the sweat glands. It is usually used in delineating the area in which we are going to inject by Botox. And there is a gravimetric. This way, the filter paper is used. It's put on the area for a certain time, and then it is removed from the area, for example, the axilla or the palm, and put on the sensitive measure to measure how much the weight has increased of this filter paper. Now we come to another subject, the treatment. How are we going to treat these patients who are complaining of hyperhidrosis? Of course, if you have a secondary cause, you must treat it. What about those with a primary cause? We have first line treatment, second line, and third line. First line, of course, you have to start with topical agents, for example, aluminium chloride, alum or shab, aluminium chloride hexahydrate, aluminium zirconium salt, and different aluminium salts. These are usually effective in a good number of patients. If they are not so, then we have to go to the second line. Acetylcholine release inhibitors, botulinum toxin, very effective and useful. Why? Because it can act for 4 to 6 months. The only side effect is the discomfort during the injection, and sometimes there is weakness of the muscles if you are injecting the palm. Another way, iontophoresis, not practice that, 2 to 3 times per week. Oral therapy, a lot of oral drugs, but all have side effects. Anticholinergic drugs, oxybutynin. The side effects, of course, dry mouth, urinary retention, especially in old people, sometimes confusion and decreased mental status. Glycopyrrolate. Another drugs, an alpha-adrenergic agonist, clonidine, an old drug used for the treatment of hypertension. It can induce hypotension and it can induce rebound hypertension. Not a very safe drug. Beta-adrenergic blockers, propranolol. They induce hypotension, bradycardia. You have to be careful when you prescribe these drugs to a patient who has asthma. Anxiolytics, sometimes effective. Clonazepam and even diazepam. If these do not succeed, then you go to thermal ablation of the area, ND-YAG laser, microwave treatment. These need multiple treatments and they are usually expensive. The third line, if the first and second line did not succeed, we go to the third line. Liposuction, you can use it once or you can repeat it more than once. It's expensive and you can remove the fat in the area together with some of the sweaty glands. Local excision, not an easy procedure. It must be, of course, used once. You have usually used, this is for the axilla, of course. The first one is also for the axilla. You have to remove all the fatty tissue in the axillary vault. There is a risk of scarring. Sympathectomy was once used and was hazardous. Now it's less hazardous because it can be used by endoscopic procedures, but there is a risk of Horner syndrome still. Usually it's a permanent procedure and sometimes complicated by compensatory hyperhidrosis. I hope that this will explain some of the features of this subject and you can have an idea about how to manage this common problem. And thank you.